Okay.
Okay, so we'll just do a quick little change in programming, and then we'll ask Dr. Sahu if he would present first, and then we'll loop back to Dr. Roy as she works out some technical difficulties there. So we apologize for that. So our speaker is Dr. Sahu, who is Associate Professor and Head of the Department of Physiology, Ergonomics, and Occupational Physiology at the University of Kalyana, Nadia in West Bengal, India. His research contributions are strongly in the area of occupational physiology, and he's been recognized with numerous awards from the government and internationally in the area of occupational physiology. Please join me in welcoming Dr. Sahu.
Hello, am I audible?
You are now, yes, sir.
Yes. Oh, thank you, Dr. Alberto, and for nice introduction. And obviously, I'm grateful to ICOH and ASSP Indian chapter for giving me the opportunity. Mainly, I am working in the unorganized sector in the construction industry. So here I am sharing some of my experience related this construction sector in unorganized or informal sector. Next slide, please. Next slide, please. Next slide, please.
Vinath, are you able to advance to the next slide? Vinath, are you there? Are you able to advance to the next slide, please?
Or I'll do it myself. Share.
Yes, please do.
Then I have to share. No? He's sharing. So,
okay, try now, please.
Okay. Okay. So I think it is now visible.
Yes, thank you.
First thing, as what is ergonomics, we are coming to the ergonomics and its relation with this occupational safety and health. So mainly the ergonomics, it is the application of the human biological science in conjunction with the engineering science. So when we are thinking about any occupational health or safety problem, we have to think holistically. It is not any one person's domain or any one subject domain. Long back in Second World War, it was first recognized that when a lot of fighter pilot plane, when coming from completing mission, they met with some accident. So people from different discipline try to find out why this accident happened, because it is not due to any casualty or any from external source. Then they found that there are mismatch between human capability, limitation, and machine tolerance. So many things, what we are receiving, we are not perceiving. Like we are receiving so many informations. Like in maybe in construction site, so many instruction is giving, like don't go this side, this is hazardous. But the thing is that the man or human who is the main worker or main stakeholder of this work, whether he is able to receiving it, that is one of the question. So next slide, please. Next slide, please. So here, ergonomic focus is on the design of the job, which is fit to the worker. Means we have to not make the worker to fit to the job. We are making the job which is more fit to the worker. So that is the concept of ergonomics, and here its application, the human-centric application of any occupational hazards or occupational problem is the ergonomic focus. Next slide. So here coming to the construction sector, especially in India, here obviously we have two type of construction sector. One is organized sector. Definitely they have the rules, they have the supervision, they have the legislation, everything. But more than 70% of the workforce are employed in the construction sector in unorganized or informal sector. And here the problem lies, because many we are depicting some of the picture how they work. Next. So the key question, how we can humanize the informal construction sector, because there are a lot of challenges. First challenge, the population, especially the unskilled worker, whoever engage in the construction site are migratory in nature. So one day they are working in one construction site, next day they are going to the other place, maybe other job. So they are migratory in nature, so they are not trained, and they are not aware of the hazardous condition pertaining to their work. Neither they are aware about the law, about the maintenance of their health, safety, social distancing, use of PPT, and all the things. And they are definitely, another bad thing is that they are exploited in terms of their wages and the hours of work. So actually here the safety aspect is coming when they are working for the long hours of work, their reflex and capability is diminished and chances of accident increase. So these are the main key challenges of the unorganized sector. Next slide, please. So if we see a depiction of actual construction worker, so here you can see what are the constraints. They are working in, as it is a tropical country, they have to working outside under the sun, but there is no proper drinking water. They are working under direct sunlight, and as I told, they are migratory in nature, so new workplace. They have to, most of the cases in case of underground sector, they are heavy manual work, uh, no proper toilet facility, and as they are paid for the productivity, they want to work more so that they can get more money. There are no thermal cooling, and different environmental dust, sand, and other cement are the hazards present in there. Next, please. So here, if we coming to the humanizing the everybody is not have the similar strength, similar height, and similar skill. Work environment, they also influence their work pattern. And another aspect is biorhythm, that is hardly we taken care of, that is in night or extended working hours. We are not as alert as that, as in the daytime. So the chances of accident is much more. And if we see, the major accidents happened either early in the morning or late in the night. So that is the another aspect we have to taken care of. So we have to be more cautious when the night work is going on or when they are working about the extended working hours. And safety culture, that is one of the important thing in unorganized sector. If it is not trained from the uh, superior or supervisor, there will be they are not following the proper thing. And as the transfer of technology is there, but if they are not aware about the technology, use of that technology, uh, that is one aspect they cannot use. And second thing is that generally they have some habit to escape the things, like we have, I take one simple example. There are some sensor in the seat belt. If they do not put the seat belt there, there will be some noise. So instead of putting the seat belt, what they do, they put the seat belt in the back side so that connection is there, so no sound is coming. So these are the certain things generally they try to avoid. They are not aware what the mistake they are doing. So the training part is very much important for them. Next slide. Next slide, please. So here some of the picture how the construction worker working in the unorganized sector. They are barefooted, they are carrying the load, and they are doing the heavy manual material handling. Next slide. And here this is some way of work. They're using so much force with unstable work without any precaution. They are working. Next please. So some more thing how they are working, especially in unorganized sector. So that should be trained by them. Means we have to train them, or we have to taken care of this unorganized sector, especially because we have the 70% of people. Next please. And here you can see one of the usual habit. Here this people, this person take a brick, throw it above, and from first floor with an unstable platform, this person is receiving it. So these are the some bad practices they usually have means usually seen in an organized sector. So these have to be stopped. Next. And here some of our study, very interesting. Obviously the site means analysis of work site injury in construction laborer. And here, although the data very difficult to get, the main thing we have seen that there are the heat by material about 29%, tripping and slipping 21%, and other causes are picking by nails and other sharp object because they are not having a proper shoes and other thing. The injury from the hand tool or container 22.22%. So these are the main cause we have found that worksite injury in the unorganized construction laborer. Next slide, please. And here number of days lost, like 1 to 3 days lost, about 28% worker in the 3 years. So 20 lost more than 3 days or almost 2 to 3 days, and almost 7 days 15% in 3 years, and obviously 7 to 10 days 3%. Actually here they are paid by if they work. So they with their injury they come to the work. So that is one of the aspects is there. The injuries are there, with injury they are coming to the work. Next. And here one important thing, body parts injured, that is the finger and toes. The maximum we have seen that the injury occurred in this finger and toes. So that is one of the PPT and other thing we have to be devised much more here. Okay, next please. And here one interesting finding, age-wise distribution means how the percentage of worker and number of injury. What we have seen, when the people join, the ratio is 1.9. So as they are novice, they little bit careful. After that, 21 to 25 means they have got some experience, so they are happy-go-lucky type. So it is increased. After that, getting some experience, obviously they will be more careful. So it is decreased. Then up to 35 and up to 40 it is decreased. But again after 40, as their body strength and reflex decreases, there will be increase in this ratio. So age-wise distribution is like this. So we have to also think about the training, retraining, other thing about this different age group. Next, please. So what will be the solution? We have to think about the sustainability. Whatever the suggestion we have to make, that should be sustainable. So we cannot have this, especially in the unorganized sector, very costly in intervention, and it should be participatory approach should be there. So people should be approach should be participatory, so they will be aware about the their what are the harm may be there and what will be the consequences, and the solution should be come from here, and some low cost innovation is there and low cost implementation. That is important, because if it's costly, it is not affordable. And safety culture, you have to grow the safety culture, because if we don't train them the safety culture, it will be problematic. Next, please. And more basic research and innovation is required, because especially in third world country, the data is limited and data sharing is also limited. So approach should be there, the data basic, more research and data sharing, so that we can plan more accordingly. And obviously biorhythm, as I already told, it should be taken care of, because it is a neglected issue. And multidisciplinary and holistic approach is required, because it is not as one subject domain. We have to think together from all subjects, from engineering background, medical background, physiological background, psychological background, so that it can be reduced. Next. Next. And here some of the good practices, what we should, although it is very low cost, this is designed by themselves, there for the carrying. It is much better than carrying, and this is low cost, some thing they are doing. So this type of innovation we have to be rectify and make it more comfortable or more scientific, so that this low cost innovation and their participatory nature will be much better, instead of taking some solution from the outside thrust upon them. Obviously, they have to be taught about the basic rules, basic safety principle, and what will be the harm there. So that is the need of the day. Next. Otherwise, if we from above, if we impose something, here we can see there is some suggestion about the workplace, change in the workplace, but ultimately the effect you see, it will be more dangerous. So there it is not match with their conception or their practice. So we have to be more careful when we are designing something. It should be come from the participatory, as I am telling, and it should be well acquainted with them, and they should be know what are the innovation is coming and what will be the new work process. Otherwise, it won't be any use. Next slide, please. So thank you. So if there is any question, I am happy to answer.
Dr. Sahu, thank you. That was wonderful to get sort of the perspective on ergonomics and the injuries that we were seeing. I was really taken back by seeing some of the injury data from the past 3 years, where almost half of them were, several days away from work. I think there's a lot of opportunities to definitely improve construction work sites and reducing injuries, so that workers don't even have to work with an injury and continue. We do have a few minutes to ask some questions from the audience and the attendees on the webinar. So if you have any questions, would you feel comfortable unmuting yourself and ask away, or you can write it in the chat, and I'm happy to ask the professor directly. So, Dr. Saho, I may just ask you a question while we're waiting and see if any other additional, if any folks from the webinar want to ask. Because it's an international webinar, could you share with the audience a little bit about some of the challenges in data sharing about injury rates that happen within construction companies that might limit some of the efforts for ergonomics? Like, how can we encourage industry to be better stewards and share, injury data and other aspects of construction injury safety to improve ergonomics?
So definitely the injury data, actually the thing is that, so there are a lot of means constraint about when a company or corporate company share their data. So there are other consequences. So generally they do not share it. But according to the thing, means according to our Factory Act, they have to report. If it is a reportable accident, definitely they have to report to the government directorate. And obviously they are keeping the incident rate of incident, means small injury and other thing in there. So that database can be shared and to plan what are the portion affected and who are the main with age and with other means capability and limitations and safety culture, how it can be improved. So with the data, definitely data sharing and analysis data sharing will be much better and hierarchy control. And I think in this regard we can say that with Dr. Shane, we have some means in the corporate sector one analysis, fuzzy analysis of this means what is the hierarchy of the control and other thing. It is well published and well so that way definitely some scientific study is required. So based on the scientific data or based on the scientific innovation, we can plan the thing. So one is policy making, which is based on already established method, and other is the science. Science we have to try many things. May not be everything will be successful. Everything may not be work. Okay, but among the five, whatever we are trying, maybe one will be work, and that may be implemented. So that way, research and innovation will be required. So that is my viewpoint.
That is very sage advice, and I'm very thankful for that. So we're going to go ahead and move on to our next presenter. Dr. Roy, are you comfortable and ready to share slides, or do you need additional time? Oh, terrific. I think she's able to. Okay, terrific. So we previously were able to introduce Dr. Priyanka Roy, who's the Deputy Director and Deputy Chief Inspectors of Factories and Certifying Surgeon for the Directorate of Factories in the Department of Labor. So please join me in giving a warm applause and welcome to Dr. Roy. The floor is yours.
Thank you so much. And so now I'm going to talk about some issues which is related to humanizing construction work. Next slide. Yes. Vinita. Okay. So basically, I will start with some data. We all know that we always, whenever we talk about any issues related to occupational health, we have to rely on the data which is published by International Labour Organization. And as per that data, we can see that 60,000 fatal accidents each year happened due to this work in the construction industry. And this is about accident. And now we can see the occupational disease. So 40% of all kind of occupational disease is related to musculoskeletal disorder, which is very much prevalent in the labor intense industries. And construction industry is one of them. Next. So there are persisting many occupational safety and health challenges already there. Some are emerging. So already we know about physical and chemical, biological. So now we need to identify the risk of psychosocial hazard and mental health. And another very important, which already Dr. Shahu described, that ergonomical factor, which is also very much related to the work in this kind of labor intense sector. Next. So health hazard first, if I start with the very common thing, and that is heat. So because of this climate change and the whole lot of environment in world that has been changing. So, and that affects the life and of the workers in whether this is factory or construction site, because of they have like direct effects, maybe burns, heat exhaustion, syncopal attack, heat stroke, heat cramps. Those are the direct effect of heat and environmental stress, and that have also the indirect effects like decrease efficiency. So more people are working, but we have been facing the issues of presentism. They are present, but they cannot give their 100% efficiency in that their work. Also, they are fatigued because of this kind of humid, hot weather. Also, that eventually that increases the accident rates. Next. Next, yes. So this is also about the vibration, which is there are segmental vibration or whole body vibration. It's very common in the construction sector because they are all day when they are doing this drilling or this kind of activity. Then segmental vibration causes hand-arm vibration syndrome. They have been facing the problem with their neurological and hematological system. So tingling sensation, numbness, blanching of fingers, those are very common manifestations because of segmental vibration. And when they are sitting all day in crane, when we can see that all around our this civil urbanization and everything. So how they are sitting all the day inside the crane, or they are driving some vehicle related to the construction work, then also they are getting fatigue, their disorder of spine, all this bad posture or awkward posture because of their monotonous job, then headache, then eye irritation. There are many things related to this vibration. Next. Yeah. Then inadequate illumination, we can see during our daily life that workers in construction, either they are working mostly in the night, all over the night when their metro rail workers or any worker in the high rise building, or in the scorching sunlight. So there is most of the time they are working in inadequate illumination, either very excessive brightness or poor illumination. And when they are working this doing welding, which is very much common job or hazardous job in construction as well as factories, so that is also a huge effect on their eye, and followed by other health related problem. Visual fatigue, eye pain, headache, those are very common. And also sometimes if the excessive brightness, then blurring of vision, lacrimation, always watering, and then headache, those are the kind of issues they are facing. Next. Yeah, that is also related to radiation, non-ionizing and ionizing. I'm not going very in-depth discussion over one issue, but this is some kind of issues very common in construction industry. So next. Yeah. So mechanical hazards, we can see like how large number of equipments those are crowded in work conditions, and also improper maintenance of equipment. I can share one case study in here just for a few minutes. One worker recently, maybe this month only, he lost his life while he was checking the one number in a pile of electric these poles. And when he was working in the midnight, it was almost 1 a.m. and he was working with the supervision of only one person. And when after this death happened, I was there to investigate, and I saw that that person was just joined this work 4 months back, and he had got no training. He had no SOP, any kind of standardized operating process, so that when he was doing some hazardous work, somebody was there, or some more than 2-3 people. So it's midnight. He was like, I don't know how he could manage, but somehow he was just slip into the pile of that electric poles, and he lost his life because of huge massive internal hemorrhage. So this is kind of mechanical hazards they are facing every day. So sometimes it's very sad that they lost their life, but yes, this is one thing we need to address. Next. He was only 28 years old. And then another very common thing, electrocution. It's very common when people are working in demolition, or they're working in the the old structure, handling, manipulation, or this kind of job. So it's also electrocution, electric shock, fire explosion, burns, all are the hazards related to electrical safety. Next. Next. Psychosocial hazard, it's in India or many other countries, we all struggle to understand this, why people are not bothering about this thing, but soon we have to talk about this. We need to understand this is the a huge hazard, and if we do not address this, there will be many other challenges we need to face. So we have to think about that the environment of that worker, whether the relationship between co-workers or between the employer and the employee, and that leads to depression, tension, irritability, and that whole lot of things have the impact on their injury, accident also. And we can see from global data, we can see, I have not shared here, that the countries where more they are so-called developed countries, but they are struggling with this particular psychosocial hazard, and where the like high-rise buildings are there, like Singapore, Hong Kong, there are many suicidal deaths of workers, those are working in this kind of sector. So this is thing. Next. Yeah. So this is another very common issue which we have been seeing like everyday news. It's not a big rare thing to see that people are stuck in the confined space when they are working in during tunneling, or for this kind of railway work, metro railway or any other kind of railways. Then it's very common there people are getting trapped, and sometimes they lost their life, and then nobody knows how many people got stuck, because sometimes they are migrating population, they're just going here and there. Maybe they're working in this state for the today, maybe after 1 week he is going to work for another construction sector in another state. So it's very difficult. Sometimes we many families, they can't even understand or know that where the person has gone. So it's a real issue which is very much common in construction sector. Next. Yeah. So now I'm coming to some chemical agents which are very common in everywhere and also in construction sector, because in India we have Factories Act 1948 where we have 29 occupational disease. Those are notifiable and compensable. So some are very much related to some agents which is also common in construction sector. So maybe lead, mercury, manganese, arsenic, all kind of these heavy metals, benzene, then chrome, phosgene, isocyanate, poisoning because of halogen. Next. So those are the kind of chemicals. Those have very bad effect on different system of our body. So this is another thing. This is caused by physical agent, maybe for X-ray or radioactive substances. Noise, it's very common. Noise-induced hearing loss. Yesterday or day before yesterday, we celebrated that noise world. Um, what they, because related to this noise, and we have to cautious about these. Noise is a huge problem on health in anywhere, so it's in construction or any other workplace. Also there are many various kind of toxic solvent, paint, glues, when people are working with the demolition of old structure and renovation of this thing, or maybe a new structure on the old structure, they are in contact with different kind of toxic solvents, so they are exposed to health hazards, toxicity in their nervous system, reproductive system, liver, kidney, respiratory, all parts of the body. Next. Yeah. So respiratory is very common in construction, silicosis. And then asbestos related disease may be the worst kind of this cancer related to asbestos, that is mesothelioma. Also toxic anemia because of contact with obnoxious chemical agent. Skin disease very common with those who are in contact with the cement. Then they have this contact dermatitis, which is also the notifiable and compensable disease. But sometimes it's very difficult to that diagnose, or people just get steroid or any other treatment and they don't know about this, that this is kind of thing they should notify to the statutory body. Also the liver disease, toxic jaundice is also very common because of handling different kind of this heavy metals. Next. Yeah. Next. So we all know the three major route. So coming to silicosis, yes, this is nowadays, like for a couple of years, we this silicosis gets a new attention throughout the world, because many patients are have got silicosis in engineered when they are making of that in that kitchen top or engineered stone, they are handling with this. So this kind of patient we also have got, and they are also part of the construction of this buildings and other construction, and we know how devastating this disease are. So in our state also, we just got our last year we got this silicosis treatment, relief and rehabilitation policy, and by this designation, I am the state nodal officer, and I have been seeing so many patients with silicosis, and whether they are from anywhere, like if he is working in this state, he will get some compensation from government, but that is not our motto. We need to prevent, we need to know where these workplaces are related to silica dust exposure, so that we can work on that issue. Next. Yeah, another dangerous fiber, which is asbestos. It's very common construction in construction site. If the building is older, maybe before 80s, so there is every chance of having this kind of dangerous fiber, which can cause this asbestos related disease. And there is one kind of cancer related to this asbestos fiber, which is devastating in nature, and worst kind of, because it's and mesothelioma. And the challenge we struggle with, it's difficult to identify whether this, like it takes 20 to 50 years to get this kind of cancer. So it's very difficult to identify and notify this kind of disease. But we have to know this, that there is a problem with asbestos in construction. Next. Yeah, this is one study done by Walters et al. In NHS, and they have got that this data they have presented, and we can see this is very recent, not very old data. So we can see this construction workers, they have got most cases of asbestosis because and they have got their pension. They have been receiving pension from that particular department, so they know that construction workers are worst kind of person, like workers those are exposed to this kind of fiber. Next. This is the different kind of health risks related to asbestos, maybe pleural plaque, it's very common, pleural thickening, asbestosis, lung cancer, and mesothelioma. So there are not, mesothelioma is only one disease because of asbestos. This is not true. So there are different kind of manifestation, but unfortunately sometimes for different nomenclature, patients are not getting their relief or rehabilitation claim or disability claim, because some doctor prescribed the different name, maybe pleural thickening or lung cancer, but it basically because of the exposure of asbestos maybe 20 years back or 30 years back. So those are the challenges we are facing during this kind of claim issue. Yes, next. Chemical exposure. Next. Okay, so welding, another hazardous process which is very much prevalent in building and other construction workers. They are exposed with the smoke, which is basically very fine particles called fumes and gases containing all kind of heavy metals, and also carbon monoxide poisoning. It's another very common issue when welding is going on in a confined space, or sometimes there is lack of oxygen, or there is excess amount of oxygen. So those kind of things are also there in construction sector. And acute exposure to welding fume, initially it irritates eye, nose, throat irritation, dizziness, nausea. But prolonged exposure, it can cause the crippling disease of people, which is secondary Parkinsonism or manganism. It's called like this, and it's very difficult to identify whether this Parkinsonism is because of any another exposure or genetic reason, or it's because of the manganese exposure, because we doctors are not trained enough to identify occupational disease in countries like India and other many countries. Actually, it is not the US or the UK where occupational disease detection or occupational physician is occupational medicine is another specialty. It's not here, so we have not been trained. But in my day-to-day inspection experience, I came across this kind of issues. So we need to ask about the occupational history and how long he has been working in there. Next. Yeah, this is also another very toxic thing, and now also we everywhere we have been talking about this lead, because WHO stated that there is no safe level of lead, and it's too much toxic for children. So if it's there in soil, in environment, so there is problem, and construction workers are exposed in this kind of lead related toxic things, maybe sometimes renovation, or maybe they related to this. We can see the pictures like that old pipes making that made of lead. So they are also exposed to this kind of toxic material. Next. Manganese, we already discussed about this. So this is welding. The most common manifestation maybe for manganese toxicity is this slow movement, then slurred speech. There is difficulty in eating, walking. I have also published one paper on this secondary manganism, and that worker has that he had been working in first in a steel factory, and then he was doing the welding work for a long time, but nobody asked him, that person, about the occupational history throughout his this treatment or diagnosis part. And lastly, after 8 months or 9 months of struggling, when he was already crippled and he was bedridden, in fact, so that time he everybody got to know that this is because of manganese. But it was too late, because we know the occupational disease are, once it happened, it's non-curable. So it's better to prevent this kind of disease. Next. So carbon monoxide poisoning, it's also very common in everywhere in the world. So it's too much like dangerous gas, we know, because we can see, we cannot smell, it's not been hard, but something it's we need to stop. And it's very rare that the supervisor or any that contractor who are taking care, who are supposed to taking care of the workers, they don't have any indicate like any kind of the gas detector. So if anywhere suddenly carbon monoxide has been like suddenly starts expelling, that there is no person to identify whether this is carbon monoxide or nitrous oxide or anything, because they don't have any kind of checking system. So it's another challenge we have been facing. Next. Noise induced hearing loss, it's very common and everywhere, all kind of
Dr. Roy, I think we may have lost your audio. Dr. Roy, are you there? Okay, I think we may have lost Dr. Roy, and I apologize for the technical difficulty. Oh, maybe she's there. Okay. Dr. Sen, are you there? I apologize to our attendees. I think we're having some technical difficulties with connection. Please stand by.
Meeting ID.
Okay, I think the slides are.
This. অথবা বলো শোনা যায়। You speak.
I think we're back now.
Yes.
Okay, terrific. Okay, welcome. We can hear you. We can hear and see the slides.
Sorry for the interruption. And yes. So Vinita. Yes, that there is, I'm not going into this data. Next slide. Yeah, there are different kind of symptoms which are very common in occupational. This kind of manifestation may be respiratory problem, cough, chronic bronchitis, chest tightness, or asthma-like condition, breathlessness. And also ocular problems, xerophthalmia, squint, because of long-term history of welding work. Also ear problem because of this noise-induced hearing loss. Sometimes it is just the beginning. If this cannot address properly, then there would be the non-reversible thing, that is NIHL. And then gastric problem also, jaundice, gastric, that stomach burning. For neurological, tingling, numbness sensation, and this kind of other health problems also, that is very common, like osteoarthritis, then hypertension, diabetes. Those are also their health related issues. Next. Yeah, so diagnosis of, and I'm just taking 1 or 2 minutes, I will finished by the time. So diagnosis and confirmation of disease, it's very important to take the detailed history. Mostly that we are not doing this, but this should be a practice of doctors who are taking care of the workers' health. So detailed occupational history, past history, and the present history, how many years he has been working in that particular present workplace, and anything the in his previous thing, because in semi-skilled or unskilled workers, they don't have any job profile. So sometimes they are doing welding, sometimes they are doing any digging work or tunneling work, sometimes they are just that loading unloading work. So it's very difficult. So that's why we need to have the thorough occupational history, then exposure assessment when they are working any, that if silica is exposed, then how much the quantity. So we need to do this with the help of occupational hygienist. Then clinical manifestation, examination, and relevant investigations. Those are the way we can know about the disease, if this is work related or occupational. Next, those are the PPEs which are used for prevention. Next. Yeah. Next. So it's basically about the how that workers' right. So they should know their right, and also this is the duty of the employer to let them know about their legal rights. So now occupational health and safety is not something which is related to privilege. This is their right of worker. So we already it has been passed in International Labour Organization, and we have to abide by this, no matter our country, whatever their doing, our countries in fact. So but we have to keep in mind that this is their basic right. So next, this is a couple of things. The responsibility and duties of employer, it should be as per the statutory requirement of that state first, and then it should be related to the country legislation. And sometimes when there is nothing, then we need to follow the international benchmark so that we can protect our workers. Next. So they should know that the workers should know their rights and duties. Next. Role of inspector, we have to have this robust inspection system where the inspection go for inspection. Also the audit system should be there. Inspectors should see that whether the audit system they are doing, the like employers are doing this kind of thing. Then guidance or advice to the head to help employers to fulfill their obligation. And then if there is anything related to like grievous in nature, maybe fatality, maybe partial disablement, maybe loss of eye, loss of hand, loss of like other things. So then it should be under, it should come under the employee state insurance commission thing. So it should be there. Next. Okay, so those are the challenge I already discussed, that under-reporting a huge thing of disease and accident. And to answer the previous question that was asked by Alberto, I want to comment on that the question was asked to Professor Shahu. We don't have this kind of comprehensive reporting system. So basically what we see when we like go for the inspection in the workplace, like industry or construction sector, we ask for their periodical medical examination and pre-employment examination reports, so that this, which is statutory requirement, they have to do this. Sometimes if they don't do, then we make them understand that this is your job and right, you have to do this. So in that way we are getting the notification and the disease profile or surveillance system we have. Next, we are getting data from the employee state insurance hospitals, ESI hospitals, we call it here in India, so that they, when they are going for their treatment, for their injury, for their back pain, for their thing. So when they are going for their treatment, there is one form 12. So it should be maintained by the ESI hospital. So we are getting data from there also. Also, sometimes we get data from the local police or different kind of the legal authorities to investigate if there is any problem. So this kind of notification system we have, we don't have this comprehensive thing. Like if you like other country, if you we don't have workers number. We put this number and we can get all the data. No, we don't have. We don't have this kind of. We are aiming to have, but still now we are struggling with that. So there is a huge problem of underreporting, and sometimes we don't have like surveillance system. So maybe one worker, he is getting treatment from state ESI, but he is getting his claim for his disablement under the central government authority. So there is no linkage between state and central government. So this is one thing it we are facing, and I am trying to, like, for my work, getting data from everywhere and trying to build up one robust system of data sharing so that we all know about this. So in this on this note, I'm going to stop. And any question you can ask me now, or any question you can, my email ID is all available with Dr. Shen. So I'm ready to talk about anything related to occupational health and safety. Thank you.
Thank you so much, Dr. Roy. Really appreciate the insight in looking at how clinical illness and disease impacts the construction sector and some of the challenges and opportunities to improve and further humanize, health within construction workers. We're just a little over time, so in the interest of time, I'm going to ask to hold questions to the end so that we give ample opportunity for our remaining two presenters to talk. So I'm going to queue up next our next presenter, who's no stranger to our audience. It's Dr. Krishna Sen. Dr. Sen has been working in the field of occupational safety and health within the construction industry for 3.5 decades. He presently leads the Environmental Health Services Department of Minerals and Metals at SPG of L&T Construction. He's a charter engineer and fellow of the Institution of Engineers in India, as well as a professional engineer himself. He's a member of several professional bodies, including the National Safety Council of India, the Institution of Occupational Safety and Health in the UK. He is a fellow, a collegiate of the Collegium Ramazzini based in Italy, and professional member of the American Society of Safety and Professional. He currently serves and provides leadership as the chair of the International Commission of Occupational Health Safety Committee and Construction Industry, as the president of the American Society of Safety Professionals India chapter, and chair of OHS Expert Committee of the Indian Chamber of Commerce. Please join me in giving a warm welcome to Dr. Sen.
Thank you, Alberto, for your kind introduction. And then, of course, it was nice to hear my earlier speakers, both of them very, nicely have expressed. I know there's a challenge of time, so I will quickly go through my presentation. I am basically from the field of construction. Is my presentation visible?
Yes, very clear. We put it in presenter mode. Yeah.
Thank you. Yeah. So if you see, I am going to talk about the Indian perspective, but it is nothing wrong to see the global perspective. And you see there are large number of people, around 395 million people are getting injured at work. And then the important thing in that, because we mostly talk about accidents and injuries, but the important thing is that the health related issues is actually consuming 88.7%. So there are a lot of health issues which, as Dr. Roy was mentioning, that don't get captured, particularly in country like ours, where the epidemiological data and the incident data and the injury data, as well as the disease data, is not properly captured. So we mostly talk about accident injuries, but the health issues. So it is the purpose of this webinar is basically to bring the humanizing part through the health aspect, and that is why we have combined this to. So now coming to the industries part that Dr. Roy has mentioned, so I will not focus on that. Maybe I will talk about the construction sector more specifically, because it has around 6 to 10%, depending on the economic growth of the country. Around 6 to 10% of the global workforce is basically, but in India, around 11% of the total workforce is in construction. That is immediately after agriculture. And we have a large number of fatalities from construction as well. If you see, I will go to the next slide, which is specifically to the Indian scenario. You will find that around 24% of global fatalities in construction is happening in India, and then around 48,000. This is a little older estimate, and then you can understand that might have gone a little higher, because in the last 6-7 years a lot of construction activities have grown up. So, but if in this data, you will find that around 38 deaths per day, which is actually 11%. If you see the global comparison, so that means almost 8 times of those deaths are coming from diseases, which is not really captured. These deaths are primarily for accidents. So if you say the figure of 40 and multiply with 8, so you will find the number of deaths perhaps which is happening per day because of the occupational health problem. So there's a quite huge concern on that, around 400 people per day. Now, the aspect of humanizing will come when we know the industry. My earlier speaker have already mentioned about it in a way. Actually, this work is basically now still it is labor intensive. I mean, the people have to work hard. We sometimes call it 3D: dirty, dangerous, and demanding. The physical fitness and and then sometimes the working conditions because of the dynamic nature of the job. Not always the company do not want, but because of the nature of the job, as we were hearing, the people are on the outside sometimes, and also the facilities provided, they have huge challenges. So there, those factors are like transient nature of the job, presence of subcontractors, because subcontractors, dilutes the requirement of health and safety, high rate of turnover, people keep on changing, low level of mechanization in couple of in major LMIC countries, and the labor issues, particularly the worker who comes to a new place, their accommodation, transportation, skill issues, and working condition, as well as extended working hours. Now, what we can do, I mean, because the problems are known. Now, what can we do? That is very important. Comprehensive safety awareness program we have to have, because people should know about the risk. Then the healthcare, basic healthcare, regular checkups, ergonomics. Dr. Sahu has mentioned about it, the importance of understanding what to do and how to do, the development of skill, because if the skill improves, then people become more comfortable at the job. They know that what to do. Otherwise, they like a lot of tension and they do not get the comfort. So a lot of skill improvement also brings improvement in health and safety, and language barrier, because in a complex project size, people come from various places in country like India. You have almost 24 of languages which are people are talking, and then the dialects and all. So I think it becomes very difficult unless we create some sort of human arrangement for them to get accustomed and get familiar and to each other, and so fair. And then what we should do is the cultural sensitivity, because people come from one place to the other, and they should understand and respect the cultural part, and by that way they can make it more comfortable for the people, particularly the younger worker. Then fair compensation, working hours is a big challenge. And then, community initiatives, employee recognition, and mental health awareness, because many people stay away from their families. And, just talking to them as a, family member can be very, very, talking something very comfortable to them can be very, very helpful. So, okay, now coming to the next. You see, ILO has, as we all know, the International Labour Conference have considered to consider that safety and health is a fundamental right in the last meeting. And labor is not a commodity. That is, of course, a long time. But then now the Labour Conference have added safety and health as a fundamental right at the workplace. So that is very important. And I also wanted to connect it with the SDGs, because the organizations, the profit-making organizations, has been asked by the governments to align with their commitment to SDG goals of UN. And there are multiple SDG goals which are having health and safety interface. For example, Goal 3 and Goal 8, very clear, but there are other goals. Goal 3 is basically good health and well-being. Goal 8 is decent work and economic growth, and there are many other goal which you can stretch to the safety and health. So the human element is very, very important, and we have to ensure that now the ESG has come. The government, the company boards are asking for ESG reporting in India. 1,000 companies, top 1,000 companies have been asked, and I think that is very, very important because with ESG focus, the companies are trying to. So that will actually help the organizations to be more careful about the people. Now, the areas, as you know, in construction is basically fall of material, hit by object, contact with machinery. So these are the areas where people can get, I'm not reading all the points, but these are the areas where we all know people can get affected. And there are other issues like MSDs, high level of noise, and of course, our previous speakers have told about vibrations and other issues like dermatitis, and these are the challenges. Now, as we know, when we talk about protection, we talk about the hierarchy of control. So it is important to identify, assess, control, and recover. So identification and and once we do that, then we use elimination, substitution, engineering control, administrative control, and PPE. So the elimination is basically to ensure that the problem is taken off. I think that is how our approach should be, and to bring it to the lowest level. Now, the intervention, these occupational health issues have been discussed very much. I would like to little focus on MSDs. Basically, the workers slowly get affected because if somebody is having silicosis and all, nobody should have, but then they will go to the doctor. It may be diagnosed, as Dr. Roy was telling, they may get some compensation, which is not enough, but the MSDs are never recognized. People accept it as a part of the job, and they keep on suffering till the end because most of the workers, we had a white paper maybe 12 years back, and we found that if someone was working for a construction site, 100% people for their whole lifetime, if they work 20 years or more, they will be having MSDs. So with this, things which we are now trying to do is that to have the mechanical lifting aids wherever possible, limit the loading, rearranging tools to enable natural neutral posture, and then rearranging workplaces to reduce excess reaching and bending. So these are the small changes which management can do. By doing that, they can have a better working environment and make the work more comfortable for the people who are at risk, and also have the awareness through which people can get other people to help them and continue working. Now, it is also important that yes, when they are working under the sun, you cannot provide a comfortable temperature, but it is important to give them rest place during lunch break and tea break. They can come in a cool place. In couple of Middle East countries, this is mandatory legal requirement to provide them air conditioned facilities, but if you cannot provide, at least provide a cool and airy place so that people can come and take rest, and and then training and awareness. Health surveillance is very important. Pre-employment health checkup is a legal requirement, but health surveillance for the people who are at high risk is also very, very important and a part of keeping them well. Job rotation and periodic breaks is also very important because people who are getting affected on a particular, for example, high level of noise or material handling, they can be shifted by half day or for a month, but they can rotate it. So that depending on the nature of the exposure, I think this is very important to have the rotation and have including or enhancing the break period so that they can be more comfortable and continue the work for a long time. Now coming to some of the things which a management is supposed to do and doing is basically on the welfare facilities to provide them a suitable accommodation, giving them the drinking water, proper sanitation, restroom facilities at site so that they can take a break and have the thing, and then also toilets and other recreational facilities at the habitat where they are staying. Now, mental well-being, I wanted to touch because many people stay away from the families. They are far away, and maybe some of them are coming after 6 months or 1 year, even particularly if they are going international projects. So it is very important that people are not stressed because of being a migratory worker or having too much of load. So some people are also getting stressed because of not having the knowledge and experience, and sometimes not being involved in the process of the job doing. So there are multiple reasons where construction workers can get affected because of, and there are also chances of suicide because, in my study, I have found this is becoming a big problem because of the stress they experience. Sometimes they're not able to help their family members in case of an emergency. They were not able to travel. So, that creates a lot of tension. So what we should do? Now, recognizing the intrinsic hazard of the construction industries, we have to take certain steps, and that is very important by the management with the Vision Zero. They understand the major challenges in the construction, which we have now discussed, and those hazards are properly dealt, whether this is musculoskeletal disorder or any other health issues, because this is primarily very, very high risk area, as we know. So it is not only the companies, but government, but also the worker unions and everyone, the industry associations, the stock exchange. Everybody is having a role to ensure that the people who are most vulnerable but working for the development of the country and the world, because all the construction actually lead to development and and creating assets and facilities for the future. So I think it is very important that the people who are working for it, the 11% of the working population, need attention, and we should come together to see those people are having the best of facilities. So the last point is basically to have the leadership, as I was mentioning, identifying the risk in advance, improving the workplace conditions and welfare facilities, and also focus on the working hours. So with this couple of steps, as we discussed, maybe we can make the construction site a safer and a decent place of work with having a sustainable life and health. So with this, I thank Alberto particularly for taking time in the morning to be with us, and all the speakers and the participants who have joined. Some people are joining after the office hours. So I am thankful to everyone. And over to you, Alberto, for...
Awesome. That was so wonderful, Dr. Sen. I really appreciate how you highlighted the sustainability goals and make us reflect and think about even the mental health aspects of the construction industry, at the organizational level, at the subcontractor and at the individual worker level. I think it's really important for us to reflect and think about how our interventions, whether on occupational illness, ergonomics, and safety, really impact that. In the interest of time, I'm going to go ahead and move on to our last presenter, and I'm incredibly thankful for her time and waiting to the very end. Dr. Priya Dasgupta is an associate professor at Southern Louisiana University in the areas of occupational safety and health and environment. Dr. Dasgupta completed her master's in physiology from the University of Calcutta, a master's in biomechanics and biomechanical engineering from the Université Technologique de Campagne. So I apologize if my French is not up to par. Spanish is my first language. And she completed her doctorate of science degree from the University of Massachusetts at Lowell. Please join me in giving a very warm welcome to Dr. Dasgupta.
Thank you. Thank you, Dr. Alberto. Now, can I upload my slide from my side?
Yes, I think just tap on the share button on the top right, and it should be able to broadcast. Yeah. Perfect.
Okay, where is that? I keep my slides open, I guess. Just 1 second. Oh, yeah, I got it. Got it. Thank you. Can you see that?
Not yet. There's nothing sharing just yet.
Can you see that now?
We do. We see your slides. Perfect.
Okay. Thank you. Thank you everyone for giving me the opportunity to talk about the humanizing side of construction. This is an ongoing study. I started this while I was in India last year. I did not have a whole lot of time there, but I had a month, and then previously I had another month in the summertime for planning this. I had been in touch with Dr. Krishna Nirmal Sen, and we have been talking about this whole research point. So this is about some case studies that I have seen in Indian construction and how we can implement some safety practices there. Just to give you an idea that in United States, we do have around 45 fatalities, and this data I took it from Bureau of Labor Statistics. Out of that 45 fatalities that welders see every year in the United States, around 5 are happening for violence by another peer construction worker or violence by animal. However, in the United States, the welders do have some type of fatalities where they are getting in contact with the object or the equipment, and that is numbering up to 22. So almost half of those fatalities are from equipment disaster, and total 45 we are seeing in the construction sector, especially for welders in the United States. In India, there is a little bit dilemma that what is the total number of welders in India. This is what I have found in the internet so far. What I would like to focus here is in Indian construction sector, what we have observed is huge missing scarcity of any personal protective equipments for the welders. I did not see the welders had any type of welding mask or any type of welding protection. They did not have any boots which is covering their toes. For this study, I had, you can say it's a convenience sampling. I had contacted several companies, but most of them have rejected that I should go and see how they are working there. Anyways, I could get only 7 companies who said yes for the participation. I could get a total of 13 participants. Since this is not a very organized occupational sector, their hourly wage is not very good, and they have a total of 9 to 10 hours shift. This is what I was, referring to. Um, I think I can actually play the slide. So as I was telling you, there is any type of personal protective equipment missing. What I was told that they are given a welding mask, and most of the time they are not very willing to use it. I do not know why. I have no way to verify whether they were given the welding mask. So what type of risks I think I have seen there, I have to actually change it like that. There is a huge risk from arc flashlight. This can even lead them to blindness. There is a huge risk for the lens injury. There is also risk for nerve damage and musculoskeletal issues. I did not expect that a lot, but it happened that while I was collecting the data and assessing the data, I did see that a lot of musculoskeletal risk exposures are there. I don't know why this is not loading here. Um, there is another video here. Okay, let me start. Grinding is also part of the welding, but what we can see here is extreme awkward posture, forward flexing, a lot of back bending. The stability is definitely an issue, what we can see from the video. And also there is continuation of static posture. So in addition to the respiratory risk, I thought that why don't I go forward? There was enough data for us from all the videos which pointed out that there is indeed ergonomic postures, very poor postures that we can analyze. So I went ahead and hello, yeah, I went ahead and I started analyzing them in three-dimensional static strength prediction program from University of Michigan version. And I did get that their posture is indeed poor. There was almost 1063 Newton forces working as compressive force in their low back. And from the data sampling period, which was very representative of their whole job, it seemed that they were continuing this posture for at least 3 to 4 hours a day. The next thing is I tried to analyze the same postures that I have seen in the welders while they are working in their work atmosphere. So this posture was not as bad as the grinding posture because this person was sitting, and many of them are having this same posture. But however, when I translated this into three-dimensional static strength prediction program, I found that even in this situation, 880 Newton force is acting on their low back, the L5S1 junction of our spine. However, this is continued for 6 to 7 hours a day. So this static posture, which they are sitting here, is continued for almost whole of the work day. I did have some chances to talk to the welders in presence of their supervisors, and they did inform me that when they go back, they do feel that there is indeed some pressure in their low back. They feel back pain. And as you can see in another posture assessment here in this picture, that the low back compressive force is quite high if we think that this is being continued for 6 to 7 hours a day, which definitely is giving some evidence that in the future they might go through a disc degeneration episode. So in addition to all the industrial hygiene exposure and ergonomic exposure, in a nutshell, what we found is that 6 to 7 hours of static posture exposure, they're going through it every day. They are having different industrial hygiene exposures, like the risk of fume fever. It's very high in the welders when they are inhaling the welding fume. Some of them told me that yes, we sometimes get some fevers. And what do you do when you have the fever? They just take paracetamol type of fever reducers. What do you do when you have any eye pain, any eye injury? They say that they apply potato and cucumber on their eyes. And of course, the symptoms will be very obvious to many of them after they have worked for a minimum 1.5 months into the welding company. Just a little bit insight into how the welding is done in the USA. This is the posture. Mostly the welders are keeping a neutral standing posture. There is a little bit of flexion that we found in this posture. And as you can see that although there is arc flash, they are definitely using the welding mask and the welding shield. This is a detailed analysis of their posture. This is more ergonomic posture as we can tell, and they go through ergonomic training as on the job training. There is less compressive force in the low back. What are the strengths and what the limitations of the study? This is still ongoing. Still, we are collecting data. In India, it was a convenience sampling. in the US, it is more or less a convenience sampling too. However, even if it is convenience sampling, we are doing the study in real field observation. So we are not doing anything in the lab. And that gives us much more representative cycles of work. We have used random hours to research the sampling. So we appeared at any hour in the work site, which gave us more or less the very representative work phases. 5 companies, sorry, some, 5 of the out of 7 companies were separated from each other geographically in India. So there was no chance of real confounding, as the workers did not have any chance to talk between each of them. And lastly, these are some of the masks that in a participatory manner next time we are trying to introduce in India. The first one is giving them a protection from the arc flash and the welding fume. The second one is for the light. And this is this is becoming a huge importance, that we do some participatory research in Indian construction sector, especially in front of the welders, to get their opinion that why or why not some personal protective equipments will get adopted or will get rejected. It's more like an effective study at this point that we are seeing, rather than the efficacious study, because we know the efficacy of the personal protective equipments. We do not need to check them again in the lab. They are already efficacious. We just want to do the effectiveness study, that why they will reject it or why they will accept it. And not only to the workers, we want to do that also for the supervisors and the company hierarchy, just to see that how they perceive importance of the personal protective equipments. That is all I had today. And if you have any questions, please let me know right now. I am stopping the share.
Thank you, Dr. Dasgupta. So I know we're just a little bit over time. We wanted to finish today at 9 o'clock, but I would welcome any question from our attendees, whether if they want to pop the question into the chat or if they want to just unmute themselves and ask out loud. Let me just say, I really appreciate the videos that you showed, sort of highlighting the different aspects of exposure as the welders are working on their individual tasks and assignments. I think it highlights all the need for this important research that you're doing with the pilot study, and kudos to you for making that data collection possible.
Thank you. Thank you so much. Any questions, any suggestions, any comments are welcome.
In the US, how the tank weldings are conducted at the lower level or piping weldings in the positions. So could you provide us some insights on how the tank weldings are conducted at the lower level or pipe welding, I guess, in the positions that they're situated in?
In the US?
Yes.
Okay, I have not had the chance to see that in the US yet. I am in the process of, that's a very good point. I would definitely compare that aspect too. What I know is they have to have the scaffolding, and the scaffolding dimensions are provided by OSHA. If they think that they have any difficulty with that dimension around the tank, they will have their own variance. That means the company supervisor will say that, okay, this small scaffold will not work. So for 15 days, we are going to have bigger scaffold than the OSHA has mentioned. But honestly, I have not seen that. I mean, I have not captured that yet. And that is in my agenda, in our agenda, because we need to compare that also. I think there was some question, yeah, in the chat box.
There was a quick follow-up on about ergonomic studies that are conducted in this regard with the welders.
How the tank will lower level of other. Okay, yeah, that's a very good question, Dr. Chatterjee, and I definitely am looking forward to see that too. Things are taking time because just to get the the permission from the construction companies, it is taking a lot of time.
Okay, so we're just a little bit over time, but before I conclude and close the session, I wonder if we would all take a group photograph for everybody that's on the attendees. So if you would not mind transmitting your video, and we're going to do big smiles and take a big group picture together. So if you would just take a moment to turn on your camera feed with your permission, if that's okay. We want to make sure we commemorate this webinar in this moment together.
From various parts of the world.
That's right. This is wonderful. Great to see so many faces. Okay, so we're going to take a big, just a screenshot of the photo. So if you all wouldn't mind just smiling, and then on the count of 3, 1, 2, 3. Awesome. Okay, so I think Dr. Sen and I were able to grab some. Again, many thanks to our chairman, Dr. Krishna Sen, to all of our presenters who took time to put the PowerPoint slides together and share with us good wisdom about how we can reflect and think about humanizing the construction industry from the various standpoints. On behalf of the International Commission of Occupational Safety and Health and the India chapter of ASPPH, thank you so much for today, and we hope that this was informational and helpful to you. Have a great day, evening, wherever you are in the world.
Thank you so much. Thank you, Alberto. Thank you. Thank you so
My
much.
privilege.
Thank you.
Bye.
Bye.
Thank you, sir.
Thank you for the nice session.